Those early patients were absolutely pioneers. They were given all the information that we had, including our uncertainty that this may not work.
Dr. Alexis Thompson is a leading expert in the fight against sickle cell disease. At the Children's Hospital of Philadelphia, her groundbreaking clinical research helped pave the way for the first approved gene therapies for this condition.
To go from diagnosing children, starting them on penicillin, to now talking about gene therapy, there's just really been an amazing arc.
We explore how Dr. Thompson's work is transforming lives and shaping a brighter future in hematology.
Being patient, being persistent, really being as hopeful as one possibly could be to see improvements that matter to patients.
In our conversation, she reflects on her journey, the hurdles the field has overcome, and the powerful hope that gene therapy offers patients and families. Welcome to Stanford Department of Medicine's Inside Look at the Future of Medicine. Well, Alexis, welcome to the Future of Medicine and welcome to Stanford.
Thanks so much. I really appreciate the invitation.
We just came from a really amazing Grand Rounds presentation you did, which was incredibly inspiring. And your whole career really has been an incredible inspiration for our residents and fellows. It's incredible to see a disease, sickle cell disease, get to the point where we can really talk about cure. It's just amazing. Just give me a sense, first of all, before we dig into the background of what is it like to be in this moment and to be thinking in that way about this disease?
You know, it's pretty extraordinary.
Yeah.
When I began my career as a trainee, it's remarkable how far we've come. The notion that penicillin would be something that would save lives for children, those papers were published when I was finishing my residency and beginning my fellowship.
Yeah.
And as I was finishing my fellowship, places like the state of California began newborn screening, in part because we knew we now had an intervention that mattered for children.
Right.
To go from just barely scratching the surface in diagnosing children, starting them on something as simple as penicillin, to now talking about gene therapy, there's just really been an amazing arc.
Well, before we jump to you, how about maybe just give us a little primer on sickle cell disease? I know that's not the only disease
That's true. It's not the only disease that I work on, but sickle cell is really an interesting red blood cell disorder.
Yeah.
It's caused by a genetic mutation in a gene called beta-globin. Yeah. And we inherit a copy of beta-globin from each parent, and both parents have to have an abnormality for a child to actually have sickle cell disease. Now, when kids were born with sickle cell, they look completely healthy.
Yeah.
So there really is no other reason to suspect that they have sickle cell, save for a family history and the fact that they now get tested at birth.
Yeah.
When they're tested and we detect it, they're referred to, the notice goes to the family as well as the pediatrician. They're referred to a specialty center to have more detailed conversations about what sickle cell is, what it means for families.
And what is the diagnostic? What is it? Is it a genetic test?
It's a blood test, so it's a prick on the heel.
Yeah.
So these are what we call dry blood spots. So children who, I think many people have seen their newborn baby with a Band-Aid on their heel.
Yeah.
And sickle cell is one of several tests that are done from that single blood spot that have allowed us to think about early intervention. That is the primary reason for doing newborn screening, is hopefully because we can do something about it.
Yeah.
And we know that children with sickle cell, if they're started on penicillin, if they're started in good, high quality care, that they will absolutely survive to adulthood and will thrive.
Yeah.
But they do need specialty care.
And so these red blood cells are kind of unstable then and can change shape.
So the hemoglobin is the main building block inside red blood cells that carries oxygen, and the mutation is in the molecule called hemoglobin.
Yeah.
And most of their red blood cells, under most conditions, look like everybody else's red cells. But under certain conditions, like stress and like low oxygen, they change shape. And that shape change can ultimately be permanent in those red blood cells, and it makes those red blood cells sticky, so they stick to things like the surface of the inside of blood vessels and to each other, and they clog up things. And so it's that clogging that causes not only pain, which is the signature of sickle cell, but also damages organs. And at the end of the day, that probably is the more important of the problems with sickle cell, is the fact that these red cells are easily destroyed, and that they get hung up in really all the wrong places, and so they affect the brain, the kidneys, the lungs, the heart, in ways that really shorten the lifespan for people with sickle cell.
What's it like to live with sickle cell then?
You know, it's extraordinary, and you almost have to ask someone who's walked in those shoes, and I readily admit every day that I am not one of them. And so I have a high degree of respect for patients telling their own story. But what they tell me is that the lack of predictability is probably the thing that's most challenging for them. Many of them can start out thinking that they have a full day plan, either going to school, going to work, only to find that they are suddenly caught up. Because they have sudden pain that can be just extraordinary and can be so debilitating that stops them in their tracks. Some of them will have some medication at home that will help some, but many of them end up in emergency rooms and hospitalized.
So for these patients, some days they can almost act like normal, but then out of nowhere, they can suddenly have severe pain.
Even with the best of care, even with them taking other medications, including a newer one called hydroxyurea, they may still find that they have these episodes where they just have unbelievable pain. The same thing is true for people who have lung disease or kidney disease when they otherwise are doing all the right things. But sickle cell damages these organs in ways that are silent. And so it's a silent, chronic injury that ultimately causes these organs to fail.
And give me a sense of how common is it? How many people are out there, both in the US here, but also globally?
We estimate that there are about 100,000 Americans who have sickle cell. It's ironic that I don't have an exact number today because they're not actually categorized well enough for us to be certain. But the estimate is there are about 100,000. There are millions worldwide. And I dare say that many of them live in parts of the world where there is not newborn screening, where there is not a way to be certain. What we can look at is gene frequency and birth rates to predict about how many people in some of these parts of the world have sickle cell disease. We know that there will be children in many of these countries that will die without a diagnosis. So they may die of a diarrheal disease or from a fever, which is probably malaria, but without knowing that their real underlying problem is sickle cell.
One of the things I was struck by in your excellent talk was that in many countries, these individuals with this disease don't reach adulthood.
Yes, it's challenging, and to think that we may have been in that same situation 30 plus years ago in this country. The realities are that 95 to 98% of Americans with sickle cell will survive beyond age 18, which is almost the exact opposite of what you see in other parts of the world. But a diagnosis is an essential part of that, including education of a family. I think there might be a mom or a grandmom that says, oh, this kid has a fever, it's a cold, it'll pass, the other kids in the household are sick, I'll just wait till the morning. You can't do that with a kid with sickle cell disease. And so just knowing that you have a fragile child, and the same thing's true for malaria. Many people in endemic parts of the world will get malaria multiple times. A person with sickle cell will die from malaria because the malaria parasites attacks red blood cells, and that is the one cell that's most fragile in sickle cell disease. And so, so tragically, they may be treating that child like all the other children in the household, only to not realize that what that child needed was special care.
So not so rare and devastating.
Yeah,
as a
absolutely.
Condition. So before we get to some of the more exciting new things that are coming, I really enjoy hearing people's backgrounds and stories and how you've ended up dedicating a large portion of your life and also leading others to this area focused on these diseases, hemoglobinopathies. But take me back. Like, when did you first know you wanted to be a doctor? When did you first know that you were going to dedicate your life to blood diseases?
So, I can't remember exactly how old I was when I wanted to be a doctor, but I think by the time I got to college, I was fairly certain this is what I wanted to do. And really, I knew two things, and they're not that different than a lot of other people in medicine, and that is that I love science, and that I want to make a difference. Now, I thought my making a difference was going to be as a primary care pediatrician in a community practice. That really is kind of what I thought, because that was the vision that I had. But as a fourth-year medical student, I met one of the people who was my lifelong mentor, Dr. Kwaku Ohene-Frimpong, who was a pediatric hematologist who was passionate about sickle cell disease, something that I didn't know enough about. But he was just an absolutely inspiring person. And I went on to be introduced to many other people in hematology oncology who, again, were doing just some really exciting things. So by the time I finished my residency, I was hooked on hematology oncology. And it was at his suggestion that I returned to his alma mater, which is the Children's Hospital of Philadelphia, to do my training and really to be among some really inspiring people who worked on not only sickle cell but also thalassemia.
Yeah.
And really being able to be in an environment where you could really imagine not only making a difference scientifically, but also to find ways to treat children to improve outcomes.
It's incredible, and I think just reflecting on your story, it's amazing how often it's a single individual that inspires you, and that you I don't know, I often wonder if I hadn't bumped into that person, or I hadn't written that letter to that person, or emailed that, you know, what might have been different. But I think so much of when we think about medicine and medical education, we think about passing that on to the next generation, and I have no doubt that you are inspiring.
Yeah, and to his credit, I mean, I think Dr. Ohene Frimpong, his initials are KOF, so many he's beloved around the world, and his initials are spelled KOF, KOF. So KOF certainly had inspired not only me, but many in this country and globally. You know, parts of the world where he was well ahead in terms of thinking about what needed to be done in areas where they're of high burden. He's a native Ghanaian, and I think really dedicated, especially in the later years of his life, to really advancing sickle cell in Ghana as well as across Africa, India, and South America.
Yeah, and we'll definitely get to the global implications, because it really is, I think there isn't another set of diseases, but where we have both this sort of local, extremely high tech, extremely high innovation element, but also the ability to have this really global and scalar impact. So you mentioned it's a genetic disease. I think certainly on this podcast here we've talked quite a lot. We had Jennifer Doudna visit recently, one of the pioneers, Nobel Prize winner of course, for discovering CRISPR-Cas9 mechanisms, and you talked about some of the new and exciting gene therapies that are not just coming our way, but in a couple of cases, 2 are already approved in the US. So give us a sense of your role there, and how you first came across the idea that this disease could potentially be treated with these genetic therapies, and give us a sense of the story from there, because it's a pretty amazing moment in medicine.
It really is. I mean, so it began with having all of the amazing scientists who established that not only was sickle cell a disease of the red cell, a disease of hemoglobin, but that it had a genetic basis, and that the genetic base of it was something that was fairly discrete and very predictable. And so with that in mind, it being a monogenic disorder, it just seemed like surely if I could just fix what's broken, I would take care of everything. And we had animal models that you could actually have an animal model of sickle cell if you could somehow fix the gene. You got rid of almost everything that caused all the complications in those mice. It took decades to actually go from having mouse models or animal models to actually envisioning how you could deliver this in a durable way, in a safe way to human beings. And my early years as a young faculty member were those years where some of those building blocks and some of those early hits, misses and hits were taking place across all of science, because many people believe that it was just a matter of time before we could figure out a way of how to manipulate genes in ways where we could actually treat diseases with genes. And so really to have gotten to the point where you could actually apply this to sickle cell I was certainly one of many who was just waiting to see that happen. For both sickle cell and a related condition called thalassemia, which is also due to mutations in the beta-globin gene. It's also interesting, so you mentioned CRISPR-Cas9, and we're going to come back to that one, but the other part of that story, the one that came out of the gate first, were lentiviral vectors. Lentiviruses, you know, we talk about, and we really talk about lentiviruses as a unique class of viruses. The most common lentivirus is HIV. And the gene, I mean the vector that is modified in this is HIV-1. Yet all the extraordinary research that went into diagnosing and developing treatments, and many of the advances in that have helped to inform how do you inactivate those aspects of HIV-1 that make it such a dangerous virus to actually, for good, to be actually able to use it as a delivery device to deliver healthy genes.
Yeah.
That also is an extraordinary story. So that between having lentiviral vectors that are designed so well to prevent disease and to hopefully treat or to mitigate certain kinds of conditions, that combined with CRISPR-Cas9, another way using these absolutely elegant tools. Again, it was how do bacteria protect themselves from being attacked by viruses? Who knew that would actually result in treatment for human beings? But again, just extraordinary science. To see both of those approaches now being applied to things like sickle cell.
You laid out so nicely just the mechanisms. It's be great to just dive into those a little bit. So I think most people would think, well, you have a broken gene, so deliver a good one, and that is one of the strategies.
Yes.
But there's a couple of other pretty interesting strategies that aren't necessarily as obvious.
Sure.
Tell us about those.
So, CRISPR-Cas9 is an extraordinary story. It is now a tool that is used so broadly, but we're very fortunate that sickle cell was the first disease for which it would actually applied in terms of it being a broad scale for a human disease. Yeah. And it meant figuring out what are you going to target. And that there were a number of questions, and there have been a number of approaches in terms of which gene do we begin thinking about modifying in a way where it would have an impact on sickle cell disease, and for that matter, thalassemia. But I do think that, that the approach of using that to modify the control region for a completely different gene called BCL11A would not have been obvious. Yeah. I think it relied upon, though, on some extraordinary research that identified BCL11A as a master regulator. Right. And so we knew that babies survive before they're born making fetal hemoglobin,
which is a different form of hemoglobin.
Absolutely, and that many of us, that when you're born you have mostly fetal hemoglobin. That by 6 months of age now you're making adult hemoglobin, but that fetal hemoglobin was good stuff. So trying to figure out how to actually get the body to go back to making it,
because those cells don't sickle.
They don't sickle. And that BCL11A, as it turns out, is a key regulator of that switch, what we call hemoglobin switching, that naturally occurring events that occur in all people, where you go from making fetal globin to making adult globin. Being able to target BCL11A, with the theory being that if I could somehow get the body to go back to making fetal hemoglobin that is non-sickling, that would be a way to mitigate much of what we see in sickle cell disease.
Yeah, an amazing biological story. So you're basically using Cas9 to essentially break this regulator.
Correct.
Or turn it down. You said there's an RNA, shRNA, which is a silencing approach.
Yes.
You sort of turn down the volume of it or break it, and that leads the body to sort of go, oh, wait a minute, I need to switch back to fetal hemoglobin.
You said it perfectly.
Yeah.
Absolutely. Yeah. And then to ask the question, would that be enough? Can you make enough fetal hemoglobin, and can you get that fetal hemoglobin expressed in nearly all of your red blood cells? Right. So all of these things had to fall into place to make this approach work.
So what does that look like from the patient's perspective? So they have these cells, and then you take them out?
Yes.
And then at some point you're going to do the gene editing, and then you put them back in. Maybe some people would think, and we'll get to that maybe it could all be done inside the body, but the moment you take the cells out, you do the gene editing. And then you also have to ablate the cells that are left. Yeah. Which, so talk a little bit what it's like from a patient's perspective.
So the patient's journey is not a short one. Yeah. And I think that it's important to recognize that. Yeah. So it's first determining if the patient is healthy enough to undergo something like gene therapy. Right. It is a rigorous process. Part of the preparation for that is beginning a short period of chronic transfusion, so receiving blood transfusions every month for 2 to 3 months. Yeah. Stopping certain medications that may have an impact on stem cells, and then having their stem cells collected. Now, when we first started doing this, we thought the only way to collect stem cells was a bone marrow harvest. Right. So actually going into the hip bone with fairly large needles to collect bone marrow. We recognized that we could do it in a much more elegant and, in fact, a much more effective way by teasing those stem cells out into the circulation, getting them to circulate a short period of time, and then collecting them in a process called apheresis, which is hooking up someone to a machine for 8 hours, a couple of 8-hour stints to be able to collect enough cells, send those to the laboratory, purify out the stem cells, and then modify those cells in the laboratory. Make sure that they're safe and that we've accomplished what we wanted before giving them back their cells. Now these cells are regular old stem cells, or to some degree. And so if we did not give anyone chemotherapy, they would be outcompeted by the cells that have not been corrected. And so the only way to make space and to create a favorable environment for these modified cells is to destroy or to reduce the number of their own cells that still exist. And so that's where the chemotherapy comes into this. I wish we didn't have to do that one, but it would seem it's an essential part of this. And so by reducing the number of unmodified cells, it makes space in the bone marrow for these modified cells to come in, to set up housekeeping, and then to continue to grow. And it gets rid of those cells that still make sickle hemoglobin. And so that has to be, I think, so that's one thing that the patient sees. And so the patient is being transfused, no big deal. They come in for, several hours once a month. The medication to mobilize the cells has some side effects, but tolerable for patients. They go back to work. When they come in to get their cells back, it's ironic that day, the day they get their cells back, so they get chemotherapy for about 4 days. So it's in an IV. Not the greatest stuff in the world. Lots of the side effects that you would expect from chemotherapy. You don't feel great. But the day you get your cells back, it's this tiny little vial that's almost crystal clear.
Really?
It's
what size?
Well, so that depending upon the approach, one of them are vials that are opened up in the laboratory and then drawn up in a syringe. So no more than about 2 or 3 teaspoons of cells. Another one, it's a packet that, if you can imagine, is about the size of a smartphone. So a pretty small little clear plastic bag that's got this slightly hazy fluid that are your stem cells. And it just gets hooked up to your IV, goes in 10 minutes, 15 minutes.
Off. They're in the circulation.
And then the patient goes back to sleep because they got some Benadryl right before they got the cells.
Right.
Good. So
that's probably some sweet dreams.
Yeah, it's an amazingly anticlimactic day. Yet that is the day that they begin anew. It takes us a little while for those cells that are stem cells, and stem cells have homing properties, and they know to go back to the bone marrow. So that you put them in an IV, but they go back to the bone marrow. They make their way there. They set up housekeeping, and then they begin to divide and begin making,
so they become little factories, essentially,
absolutely,
of new cells that are fixed or that are
and we hope it's permanent. So that's the other part of this. We'd love to make sure that these are cells that are being returned to the person in high enough numbers and that are durable. The cells will reproduce themselves over and over and over again inside the bone marrow space. During that time, the patient's in the hospital, and they're not necessarily having the best of time. And a lot of it is the side effects from the chemotherapy. As they recover from the chemotherapy, their tissues heal. So, for instance, many of them have mouth sores because from the busulfan. Yet when you start making new white blood cells, it allows that to heal up. And so many of them start feeling better before they leave the hospital because their white blood cells are coming back in, their platelets are coming back in, and then their red blood cells come in. Then they go home. And for most people, that is the last time they're ever hospitalized.
So let's pause there for a moment because you showed these amazing plots, early data already from the different trials, which I think you call the swimmer's plots, where you see an individual patient on a row and a little red dot every time they have a hospitalization. Isn't it? And they're, on the left side, it's just like red, multiple, because that's the lives that these patients lead. And those aren't trivial hospitalizations. Those are like intense pain, crises. And then there's this moment when they have this therapy that you just described. And then for most of the plots, the right-hand side is this the odd little red dot, but almost nothing for most patients.
I'm not sure that I could have actually foreseen that when we first started this, that this would be so transformational. In fact, when I did the first patient at my institution was now nearly 12 years ago, and she had thalassemia. At the time we said, if this works, this could be transformational. But it was really not certain. Those early patients were absolutely pioneers. They were given all the information that we had, including our uncertainty, that this may not work. I don't know that we could have actually gotten to where we were not for their courage.
Well, and these plots are also much longer on the right. Like the right side goes on like this. So you're talking about a patient 12 years out?
Was able to go to college, was able to go to graduate school, was able to return to her parents' country of origin,
Wow.
all without the benefit of blood or medication, continuing to live her best life in ways that she wanted. I mean, she was very clear that, no, I want this.
Yeah.
I have dreams for myself, and if this can help me achieve those, I want this. I had nothing but admiration for her and really for many of those early patients. Today, I'm far more certain when I talk to families, now that there have been hundreds of patients who have undergone gene therapy, that I'm much more confident. It's not without some risks, but I'm more confident that this approach will work.
Yeah. It's just, I think, back to the point we made at the very beginning, the idea that we could talk about curing a disease, especially one as devastating as this is, just makes for a remarkable moment in medicine, and it just, I think, must be really exciting to be there and to be able to be meeting these patients before and offering them this hope. We talked about the burden of disease globally, and so of course these are incredible therapies.
Yes.
And you say hundreds of people, that's amazing. Of course, you mentioned at the beginning there's hundreds of thousands, potentially 100,000 in this country and millions around the world.
Yes.
These medicines are cost effective but not cheap. So
Correct.
Let's start there. How much do they cost? How do we think about scaling? And importantly, how do we think about the large population of the world? Because we have a responsibility to the entire world.
The two products that are commercially approved are $2.2 and $3.1 million. And that certainly is the quote-unquote retail price of these. They have actually, when compared to the lifespan, the lifetime expenses of sickle cell disease for people that are age matched for those individuals, it compares favorably. That does not at all mean that it is inexpensive. And it's a major hit to the system when there is a one-time, we talk about sort of cost being extended over a lifetime versus an insurance company or a state that's being asked to pick up a tab at one time, at one moment, that's that steep. It has taken a lot to imagine that. I think many of us have hope over time, surely we can find ways, even with the current approaches, to make them less expensive. Because to think that we could make infinitely more expensive products when that is the price point that we're at is not sustainable. I don't believe that anyone thinks that it is. And so the question is, how do we actually approach innovation, transformation, but making it so that it is a model that will work for more people?
Your point though is so well taken, because I think people hear that sticker price and there's a sticker shock. But if we go back to the swimmer plot that you mentioned and all of those red dots, I mean, you don't get in and out of a hospital, especially not with a crisis, short of the system or somebody paying tens of thousands of dollars.
Yes, I think that's absolutely correct. And then, you know, it's always hard to put a price tag on shortened lives. Economists have an extraordinary way of estimating those, but I think when we think about the number of people with sickle cell who are dying in their 30s and 40s, and the number of years lost in terms of their productive lifespan, that also is an extraordinary calculation. And again, if gene therapy works, if gene therapy is actually considered before they have major injuries to organs, that also is favorable.
It would be cost saving in the end.
One can only hope. It's not for everybody. It's not without some risks, and it's so important for us to be as candid as we can with risks that are known, including risks that are not known, with something like this. And there are some who have found that their disease is manageable with medications and with family support. And so not everyone is rushing to have gene therapy, but many are very excited that the investment is being made, that the kind of research that's being done that could be transformative is focused on sickle cell disease. I think for many people in the sickle cell community, even if they personally are not interested in gene therapy, it's extraordinarily rewarding to them that when they often felt that their disease was so neglected, that they as individuals were neglected or invisible, to think that there has been so much attention now being paid. Many of them are just, you know, they are so proud of actually being a part of the conversation and being involved in this major advance in science.
And you talk so eloquently as well about the idea of bending the arc of the moral universe towards justice as well, because this is a disease that has affected historically underrepresented groups. Again, not just in this country, but around the world. and that by making these sorts of therapies available much more broadly around the world can be a route for all of us towards correcting these historical inequities. Talk a little bit more about that and what it means to you.
Some of it is really having to be patient. And so, certainly the early part of the arc was simply just the discovery of the condition itself, the fundamentals of sickle cell disease. And then being able to find one or two medications that bent the arc a little bit, knowing that newborn screening, that heel prick that seems simple as ever, could actually, that and education and some penicillin, that could move the needle a little bit farther. But then just long periods of time where discovery wasn't really moving the needle toward things that matter to patients. Being patient, being persistent, really being as hopeful as one possibly could be, just hoping that that arc would continue to see improvements that mattered to patients. My hope is that are we there yet? No. Is gene therapy a breakthrough? I believe it absolutely is. Will it get every patient on this planet to where they want to be? I don't think so. At least not in its current forms. But these are major breakthroughs, not only for sickle cell and related diseases, but across all of science. And the application of this approach, I think we're just beginning to scratch the surface on what that will be. Making this safer, faster, cheaper, I think are achievable.
This is, I think, as your point, you're making the tip of the spear really for all of genetic disease to come under the potential realization of these sorts of cures, and this is one, of course, with such huge impact. You talked towards the end of your talk about the possibilities for the future, and we could feel as you're describing what the patient goes through that this chemotherapy part is the worst part.
It's not fun.
If there was a way to not have to ablate your own cells and to deliver a therapy essentially into the body as it is, what are the chances we could be looking at that?
So I think that there are a few approaches that are really promising. One thing that I didn't talk about earlier today, but that really I think has great promise, is the possibilities of a way to selectively deplete the stem cells that are abnormal. And so this is using the approach that it seems most promising is using an antibody that identifies a marker on a stem cell and depletes only the stem cell. And so all of the other healthy cells in the body are spared the ravages of chemotherapy that we currently have subject the entire patient to. If I could just only reduce those cells that are defective, it would allow me to actually do that and at the same time put in healthier stem cells. I think so antibody-mediated or some other way of depleting stem cells is certainly one approach. The other is trying to find ways to deliver the cells in ways that do not require myeloablation. And so, those things would be in vivo gene therapy that are already being launched in other conditions. So conditions, for instance, where one of the genes of interest is expressed in liver cells, for instance. So using what are called AAV or adeno-associated viral vectors. Clearly a lot of early work in a number of different conditions makes me very hopeful about that. That approach is imperfect for hemoglobin disorders because AAV viruses don't tend to target the bone marrow. But it does, as a proof of principle, begin to look at ways to think about delivery without depletion or destruction in the way that our current approach for gene therapy for sickle cell requires. Lipid nanoparticles is just an amazing potential device for packaging materials that you could inject into the body. And so, that the machinery could go to work, by being targeted by the lipid nanoparticle to a particular tissue, having those things delivered, having the modification take place, all in an entire closed system of the human body would be extraordinary. And I think that that's possible. There's still some work to be done. I think we're still years away from that approach, but I think the proof of principle has already been established for that. I'm hopeful that sickle cell will be yet again one of the diseases that is strongly considered as a target for using lipid nanoparticles for bone marrow-based or hematopoietic stem cell-based conditions.
It's been an incredible journey for you, for the community, for the patients who've been suffering and the families. Really fun conversation. Thank you so much for coming to Stanford and sharing this incredible work. And thank you for joining us here on The Future of Medicine.
It's been really my pleasure. Thanks for the invitation.
So great to see you.
Yeah.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.